TopMedTalks.
Monty Mythen here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on TopMedTalk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
I'm Desiree Chappell, host of the TopMedTalks session here, and I'm joined by Editor-in-Chief of TopMedTalk, Professor Monty Mythen.
Desiree, great to be back.
Hi, yes. Please introduce yourself, special guest.
So I'm Hugh Montgomery. I'm a professor of intensive care medicine at UCL, and I work with Monty occasionally, and we're next door to each other in offices, so we interface on some interest, but share very different interests too. So Monty's been busy interviewing people today, and I've been busy sharing things and looking at poster sessions and so forth.
So Hugh, if I may, this is the Intensive Care Society annual meeting, the state-of-the-art meeting, and you're on the board. Is it the board it's called of that society?
That will do, yes. So I'm one of the team.
And part of the team, we were reflecting earlier that this meeting has been a great meeting for a long time, but it's occasionally had a few bumps downwards and is really on the up and up at the moment.
Hugely.
Yeah. But what happened there? A couple of years ago, there's a jolt of something?
Yeah, I don't know, because I was the recidivist here. The youth, I suppose is what it is, came in and wanted a different sort of conference. And I suppose the truth is, intensive care had rather run out of things it could talk about. We'd done rat strangling for years, basic science, which had just not translated into anything that worked. And we were running out of those things. People were beginning to realise that process measures, quality improvement, these sorts of things, doing what we know works right, was important. And people were also fed up with having people like you and me sitting there on the stage, going on and giving our slide deck for an hour, and they wanted to interact. So the juniors were saying, we want this to be interactive. We want people to talk for 20 minutes, but then have 30 minutes of conversation. We want Twitter feeds and all that stuff. And I said, this is crazy. This is not a proper conference. And it's been massively successful.
Yeah, no, it absolutely has, and it was really exciting. I was in the second session in the heart failure session, the cardiogenic shock, and it was jam-packed.
Yeah.
You could not get into the room.
Yeah.
Barely, I was sitting on the floor in the very, very back. And, it was just, the Twitter feed was going crazy. Lots of great questions, lots of great several great presentations. And the panel at the end was just fantastic.
Yeah, Susanna Price was doing that, wasn't she? For my money, must be one of the finest cardiac physiologists in the world. And she does it hands-on, day in, day out.
Yep.
So you get a proper discussion about patients, not an ethereal paper-based one.
Yeah, and that's what I loved about it. It was so real, and I guess you can listen to lectures, of a study after study after study, but when someone's talking about, well, this is actually the practical use of that, that's something we're really, emphatic about sharing here on TopMedTalk. But when you're at meetings like this, I think it keeps it dynamic, and it's been really great.
So what was it? I wasn't there for that session, but so what was the take-home message for me as a practicing intensivist, do you think? What was she promulgating?
Well, I was talking to Monty about this and sharing with him that, she... First of all, about training of the intensivists and having heart failure specialists and making sure that people were aware, because, sepsis and septic shock is very different than cardiogenic shock, and sometimes cardiogenic shock, with several etiologies and all kinds of problems going on, is sometimes difficult to identify, and if you have specialists in that, it's really important. But one of the other things that I was talking about was the fact that PA catheters are kind of having a renaissance or rebirth.
So just wondering, Hugh, when we were growing up in intensive care, there wasn't much to teach us, basically.
Right.
Maybe antibiotics.
Yeah.
If you either went then to a unit that worried a lot about the lungs, or you went to a unit that worried a lot about the circulation. I think you were lucky enough to be trained just across the water here by Ron Bradley at one stage, I think.
Very much so.
And the PA catheter might have been called, as opposed to Swan Gums, the Bradley
catheter. Yeah.
Tell us a little bit more about that, Hugh.
Well, the story goes that he had, I don't know if this is true, but the story goes that he had one or other or both of them working for him as students. He'd already come up with the idea of the pulmonary artery flotation catheter as a way of measuring left atrial pressure, and created it, and they went away and patented it. So when we were there, you couldn't buy a Swan-Ganz catheter because he had his own ones made, and we had Bradley pulmonary artery flotation catheters because he was so cross.
Oh my God, I had no idea.
I don't know if that's true, but that's what we were all told.
They were told.
They were certainly true. They were Bradley pulmonary artery flotation catheters.
So moving quickly on from that, congratulations to Dr. Swan again.
Yes, no doubt.
But as I remember you telling me stories, is that part of, if I may, Ron's teaching was very much the clinical evaluation of the circulation.
Absolutely, and I say this to my juniors now, and it's without question the single most important thing I've learned in my entire medical career was the way Ron taught us to clinically evaluate the circulation. And it's not that I'm particularly clever. Anyone who got taught by Ron can do this, but against any form of gold measure of stroke volume, I can be within a couple of mils. I mean, less than 1% mostly, reliably. And he taught us a system which he'd worked out for himself, and I still use it, and it's incredibly useful.
But he also used the Swan-Ganz catheter as it subsequently became known. And we were reflecting on the fact that part of, I think, the messaging is the Swan-Ganz catheter, the Bradley catheter, is undergoing a renaissance.
Well, if this is true, I personally have a bias in their favour. And when the trials were being done about whether Swan-Ganses worked or not, and it was concluded that they didn't, I had it out with a couple of the investigators to say, look, this is a bit like suggesting that you want to find out whether driving Ferraris is safe. If you want to work out whether they're safe and you can get from A to B quicker, you need to teach people how to drive it, so they understand what the controls are, what happens when they do things, how to operate it best, and then they'll get there safely. But they said, no, this is a pragmatic trial. We're just going to let people run with it. Well, that's like getting a bunch of people who don't know how a car works or what the controls are. And it will end up with some getting there and some crashing. If you don't know what a West zone is, and you don't know whether, tricuspid regurgitation will affect your injectate, and you don't understand, a bunch of these sorts of issues about free-flowing MR, then the answer you'll get will be a lemon, and you won't know how to interpret the results.
Yeah.
And the trouble is now, certainly in our own unit, the number of people who understand, if you start asking for a swan and a sheath, people start getting quite twitched, actually, because they've lost the skill set.
I was going to say, it's probably been lost. I mean, it's really lost favor in the last 10 years. And I think the point was not that we just start throwing them into everyone again, but, being very selective and actually considering them a lot more quickly than we may have in the last 10 years.
So I don't know if you picked up on it, Hugh, and I think it may have been referred to in the session. Andy Shaw published relatively recently, I was privileged to be a co-author, a large cohort study, sort of re-challenging the Connor study about the use of PA catheters.
Oh, right, okay.
The hypothesis was, it's interesting to note that although the numbers dipped of the use of PA catheters, in cardiac centres they kind of divided themselves into all in or all out.
Right.
So they did an analysis of just under 7,000 patients, did propensity matching, and asked the question, did as much matching as they could. What were the outcomes like comparing those who stuck with the PA catheter compared to those who abandoned it? And maybe it's not surprising, in terms of mortality, heart failure, length of stay, ICU stay, they're all statistically significantly better in the PA cathetering using centres. But interestingly, there's an increased infectious morbidity in the PA catheter, which actually turns out may need to be urinary tract infections.
Whoa. Oh, that's the magic pixies carrying me.
There are theories. There are theories they're exploring about that, about persistent use of measurement of urinary output in patients who are having their hemodynamics managed more closely. But they're working on that.
So, I mean, what's your instinct?
But there's no hint of harm from it.
So, what's your instinct? Is that because actually using the data from a PA catheter is a better thing, or is it because when you've got people who really understand cardiac physiology are therefore confident in measuring those things that you'll get just getting better cardiac physiologists? What do you think?
What I've seen, it's a bit of both.
Right.
Is that if you're very interested in hemodynamics, you're more interested in measuring things, and therefore maybe it's just a surrogate for better doctors, better teams. And that's going to be really hard to tease apart. But I think if you decide you want to get into using a pulmonary artery catheter well, I don't think anyone can make you do it. But if you decide to do it and do it well, you can say, well, it doesn't appear as though it hurts people. That allegation was unfounded if you use it well.
Yeah, and I don't think any of us here are saying that if you've got a Monty Mythen who's a young, fit Adonis of a man sitting here with normal ventricles and normal valves and normal pulmonary arteries, that actually,
one of those is right.
You sort of you can work out, given RV loading conditions, what the LV will be loading, and you can measure its output. But the problem for me always comes where you've got an impairment of contractility of one side or the other, and particularly on the right side. So for me, high PA pressures, some evidence of impaired RV contractility, a bit of TR, whatever it might be. I can't tell genuinely what the loading conditions of the left ventricle are accurately. And that's important if you're trying to avoid cardiogenic pulmonary edema from having high left atrial pressures, or trying to optimise LV output. What's the wisdom? You're meant to keep giving them fluid challenges and see if what happens to CVP versus cardiac output when you don't know what the wedge is, and then start looking for, I don't know, for ultrasound evidence of lung water. It'd be much easier to have a swan in, I think, and getting a wedge trace.
Yeah, because the catheter was originally there to be, it's a right heart catheterization, isn't it?
Correct.
Then exploiting the inflation of the balloon.
Yes.
In the correct area to have a column of blood, effectively, a manometer into the left heart.
In an unvalved, so the idea, of course, is, exactly, no valves, no flow, the pressure equilibrates with that in the left atrium.
But the reason it's having a renaissance is with echo, a lot more people can see there's a lot of right heart failure, a lot of tricuspid regurgitation, a lot of issues, a lot of secondary compression of the left heart. But when they walk away from the bedside and the echo goes away from the bedside with them, and the nurse is left there doing the hard yards with the trainee doctor, the advantage of the indwelling monitor used well is you now have a monitor of right heart.
Yeah, it's interesting. You're just making me think then. I mean, I don't work in a cardiac centre, so I don't have to do this anymore, really. And the very rare occasions I just put it in. But having an ultrasound look at the right ventricle as you did wouldn't half make life a lot easier. Do you remember those days of, not knowing whether it was coiling up or coming backwards and goodness knows what? Presumably you could look at it float through. When it was easy, right? Sometimes it was...
But for the placement perspective, but also I don't think we thought a lot about the right heart. You may have done it where you were trained, but we regarded it very much as a sort of reservoir. The idea that right heart failure impeding left heart failure, we understood tricuspid regurgitation, high pulmonary artery pressures, but the right heart has really come into its own in the last 15 years or so.
Well, I mean, there is a book I would commend. So Ron Bradley, who did all this work, he was the first person to catheterize a right heart. So he was the first person to put in a large venous cannula. And you can always tell people who were taught by him, because the technique was one he just sort of worked out from an anatomy book. And we put them in a way that people would think was completely weird, with a vertical approach at 90 degrees to the skin surface and so forth. Because that's how he did it. So that's how we were taught. So he wrote a book, having done all his studies of human cardiac physiology, and it's called Studies in Acute Heart Failure. And I'm sure it's possible to get hold of copies of it, and it's certainly the best discussion of cardiac physiology I've ever read, and it's pertinent to humans. And he describes 5 classes of what you would call heart failure, several of which aren't, for instance. So... beautiful book, well worth reading if you can get hold of a copy. Studies in Acute Heart Failure by Ron Bradley. And he used to plot the Starling curves from his assessments of RV and LV, and he made a little handheld computer. This was even in the 80s.
I was going to say, when was this?
This was even in the 80s, and it would plot the two. It would show you the RV curve and the LV curve, and you could look at the relationship between the two. It would help guide you with how much filling would get you how much increased output. And if the intercepts were too low for stroke work, he would say, well, this one's not going to do. And you'd say, but she's young and I want to really go. He said, you can if you like, but she's going to die. And he was always right.
Yeah.
Extraordinary man.
Yeah, that is really interesting.
So I was in nutrition. Oh, so was there anything else in the part one? Because
Well, they talked a little bit about some echo, and the big takeaway, another big takeaway was to befriend your cardiologist and and work collaboratively as a team.
And slightly more subspecialized units in certain places. Which many places can't deliver. But where you do have bigger and bigger units, some of us are thinking we should perhaps look at the a bit more like the US model, where we segment it up into the subspecialist areas.
And you know, I usually ring Susanna. So when I've got a really tricky cardiac thing in a district general hospital, and I'm thinking this is just a bit too complicated for me, I ring Susanna to discuss it, and without question she says, why don't I just come up this evening? And you get a really... That's the thing for me. You don't have to move the patient. You can serve the expert.
So the takeaway message from the session is...
phone a friend.
Ring Susanna.
Know when to do that. Actually,
Susanna,
there were a lot of...
I know.
You're going to get
giving your number out.
Couple of phone calls. He's writing it all over the exhibition hall here. Another question that you got that we were hearing a lot was that where are the networks for this? And a lot of people said, well, I just phone a friend.
Well, we really ought to formalise this in medicine so much. We've got this fixation with the fact we move a patient to a specialist centre, and if we could just help fund that to make it easy for someone to come and give the opinion, it could save so much grief. Because very often you're doing the best thing you can, and sometimes the answer just requires the intellect.
Right.
And we had that in the opening session at that final bit, the organophosphate. I know we keep coming back to that, but they did a fantastic job, and then they phoned a friend.
They did.
Yeah. Absolutely.
Yeah, and they said, no, you can keep the patient there. Which he did very, very well.
He did.
You're doing just great. But here's what you should think about. And I absolutely agree with that. So if I may, I was in the nutrition session.
So what did you, what was the takeaway there, Monty?
Fantastic session.
Yeah.
Really, really interesting. One takeaway is...
having a takeaway in a nutrition session.
I don't know how to express
takeaway.
I felt very reassured that the little I think I know about nutrition is about on the money.
Yeah, because we still don't know.
We're still,
protein is not the end-all, be-all.
20, 25 years ago, we were playing with metabolic carts. We were trying to measure with indirect calorimetry energy levels and matching feed to it.
Yeah.
It's never really got traction. That was reflected on the first excellent talk to say, although it's in the guidelines, it happens very, very rarely. And then we got into the whole issue about protein and protein feeding, and then we got into some of your work with Zudin, etc., which you can probably tell us a little bit about if the body doesn't want to use it, then you probably can't do much to force it. My big takeaway message, which I wrote down, which was reassuring in one way, is when it comes to protein, early on, don't worry too much about it.
Yeah.
But then go more at some stage, and then go way more. I think I didn't get a chance to ask is how do you judge when you get to the more and the way more points? And I've got no idea how.
I don't think you can. Right. I don't think you can. So this is an evidence-free zone largely. So what I should tell you is my innate bias and opinion, which is probably has some evidence behind it, but it certainly isn't truth. When you are proper sick, you have no appetite. Your body is saying, do not feed me. It's not that necessarily you feel nauseated, you're just going, I really, really don't fancy eating at all. It looks very much as if there's good reason, and teleologically there would be. Right? If you get proper sick, you don't want to have to be starting to stagger around the countryside in search of some bird you can shoot with a bow and arrow, because you're going to get eaten by the saber-toothed tiger. What you're going to need to do is sit still. You're going to have to change your metabolism to say, I'm not able to eat now, I'm not able to exercise, I'm not out doing stuff, so I'm going to have to change the way I function metabolically. And you're going to have to try and optimise it for the bad thing you're likely to have got, which is unlikely to have just been straight hemorrhage, it's likely to be infected. So to cut a very long story short, there are good data to suggest that you can't use the fuel that you're given. And we are giving people energy-dense foods into neck veins or into their stomachs through nasogastric tubes, and we're using a lot of fat to do that because we can't give people hypertonic glucose for all sorts of very, very obvious reasons. It turns out from the studies we've been doing, led by Zudin Puthacheri, whose work this is, shows that you can't do that beta oxidation. You can't use that fat. So you actually end up dumping those carbons as phospholipids in tissues, which isn't a good thing for you.
Yeah.
Now, the second thing is a lovely paper. So we went down this line of saying, well, maybe you don't want to be fed in the first bit. Your body's saying, I don't want to be fed. Maybe actually first 5 or 6 days it doesn't matter. And all the evidence we showed in our studies was that it didn't matter how much you fed people. You couldn't use the protein and the nutrition, at least in the first 5-6 days.
And that came out in the session. It seemed to be with almost anything you fed. Yeah. So it wasn't as though the carb was going to fix it or the protein was going to fix it.
That's right.
So it's just anything.
And let's bear in mind that nearly every study so far that's tried to optimise and maximise input in that early phase has been associated with either no benefit or an excess mortality.
But that was the bit I was hearing again. There was a little bit of controversy about that, particularly with the protein bit.
Right.
An early protein load may be associated with a worse outcome.
Yes, I personally, given that it's an evidence-free zone, were I critically ill with a nasty septic shock or something on your unit, I wouldn't want you to feed me for the first 5 or 6 days. I've got little evidence that I would be harmed by not being fed, and there are some data that would improve you. And the other bit for this, I suppose, is a little bit obvious, that I don't know if this plays in the United States, but in England there's always this phrase, feed a cold and starve a fever. Is that something you...
Yeah, I've heard that.
Our grandparents used to say this. And there's a lovely study in Cell, maybe 2 years ago.
You pause on that for 1 second, Hugh, so that's get a bit of a head cold, sit down in front of the television, open a box of chocolates, eat
and
the
have
whole
a
lot.
scotch at bedtime, and that's right, load up with the carbs,
I would say a bourbon.
As opposed to a bourbon, whatever you
honey
fancy.
and lemon. But
but eat the fridge, basically. But get a prop, not man flu, but get real flu.
Real proper sickness with
can't get out of bed.
E. coli sepsis or whatever it might be, raging pneumonia, then no appetite, and don't try and force feed yourself.
Yeah.
So what they did was showed that, of course, when you starve, you overwhelm beta oxidation, you make ketones, and we've done some work showing ketones are not just fuels, but they're metabolic switches.
Yeah.
What this study that was absolutely beautiful was to say, well, why would they just be a metabolic switch? Would they not also be an immune switch? To say, look, I'm starving now and I'm likely to be horribly infected, and therefore let's do something about it. And what they showed was that if you took the starved rodent models, you took the rodent models rather with a viral infection, and you starved them, they did a lot worse. But if you take the ones with bacterial infection, the septic animals, and you starve them, they do dramatically better. And they were able to demonstrate why. It was a beautiful study of innate immunity and T-cell function and so forth, to demonstrate there's reprogramming of immune systems by ketones. So there's very good reason to say, maybe we're making a rod for our own backs by preventing that ketosis.
Yeah, so the early feeding thing is maybe not, that whenever I was working in critical care, that was kind of the thing to do was, we want to early feed all of our patients and not starve them.
And I guess all of us here have been through this cycle, haven't we, where we started no one getting fed, then it was a question of, hang on, there's this massive metabolic rate from sepsis that you've got to feed them, and then people saying, well, actually, they don't seem to have a massive metabolic rate, so maybe we don't have to feed them much, and then it came, we need to hit more targets. But Monty, I remember him saying to this, we were both doing a study called Calories a few years ago, which is about early parenteral versus early enteral nutrition. And the call was from our National Institute for Health Research. And I remember we did the study because that's what the study called for. But I remember Monty saying, this study would have been so much better if the call had been for a feeding versus not feeding at all study. And we still need that study, in my view.
Do you think that when it is right and you're ready to use the proteins, that piling them in will help?
Well, what we've shown was certainly we looked at up to 10 days, again, Zudin's work, but with repeated muscle biopsies, you find, to start with, you can't use the protein. You can't use it. You've switched on your catabolic pathways, so you're stripping muscle out, and you've switched off your anabolic pathways, so you're just stripping out muscle, end off.
Yeah.
At some point, where we was between 6 and 10 days on average, what you found was that you'd switched on still the catabolic pathway, so you're still breaking things down, but you've now switched on the anabolic. So I view that as a bit like revving the engine at the traffic lights.
Yeah.
It's roaring away, but you haven't engaged the clutch. And at some point after day 10, you're going to kick that in and say, we've now switched off the protein catabolism, only the anabolism is working, and now we can start loading up. But we've got to bear in mind...
How do you work that out?
I don't think you can at the moment. That's the problem. We haven't got a biomarker for this yet. So we need a biomarker for it. But, of course, the bit is as well, as we all know, that you can't turn yourself into an Arnold Schwarzenegger by just eating pizza and watching telly. You've got to load the muscle for it to grow. So my general feeling is, whilst you've got to put the protein in, if you've got to regrow the muscle, we're going to have to do something. We're going to have to get people to start exercising. You're going to have to do something to give it an anabolic stimulus. Otherwise, it's not really got one.
Yeah.
And giving different amino acids?
Yeah, it's interesting. So, again, I think...
It's a very clever diagrams. I sort of remembered some of the pathways, but where the different amino acids can come into the energy pathways at different points, and therefore there might be a route in.
Well, it's true, and it's not just a question of whether they're energy pathways either. So, as you know, Monty and I worked on the Extreme Everest programme of work, where we were looking at the impact of hypoxia, and one of the things we found was that at high altitude you lose a lot of muscle, and part of that is through hypoxia-inducible factor signalling, which is a transcription factor, which is a programmed way of switching off muscle growth, which makes a lot of sense when there ain't much substrate around.
Right.
Interestingly, we find exactly the same thing in the critically ill patients. So it's not, as far as we can tell, that they're hypoxic. So unless there's microvascular problems, the oxygen tensions in the blood and the oxygen carriage and the cardiac output things were all fine, but HIF was switched on as if they were hypoxic. And of course, HIF is switched on.
What's HIF?
Sorry, hypoxia-inducible factor, this transcription factor that's normally switched on by low oxygen levels. It is switched on by cytokines, and it is switched on by lactate. And I think HIF is misnamed. I think it's a bit like tumour necrosis factor. The problem is you give things a label, and you think, oh, that's something to do with hypoxia. I would call HIF metabolic regulatory factor or something of that ilk, because I think what you're doing is using the same system when you're critically ill to regulate the metabolic function downstream. Now, bring you back to your branch chain amino acids and so forth, there was a study that looked at this in muscle wasting and altitude. It wasn't our own group, where they used branch chain amino acids as an anabolic stimulus to get in. There are lots of reasons why that might work.
Where do we get those in foods? Where do we get branch chain?
Now you're really testing me. I can't remember where you get your branch chain amino acids from.
But we're getting them every day of the week, or you have to...
No, you aren't getting them every day of the week. But I'll have to look that up. Thank you, Monty.
Sorry.
No, it's fine.
I wouldn't have asked if I knew.
Can someone mark this down? At least you didn't know.
But certainly the supplements of branched chain amino acids.
Clinton will know.
Clinton, what does branched chain amino acids? What foods are high in branched chain amino acids? What foods are high in branched chain amino acids?
Look it up, Clinton. Okay. We'll pretend we know in a second. We can have this cut in.
But I suppose the question still comes, if your body is doing this in a programmed, systematic way, do you want to short-circuit and get round it? You probably don't. I think your body's telling you that this is not some random breakdown. This is a structured process that it's doing for its own benefit. So,
tens of thousands of years of adaptive progress to this point.
Yes. And we should digress very slightly, but I don't know if you saw... DeepMind Health's, well, actually, it wasn't Your Health, it was DeepMind's beautiful paper on computer science and evolution. Did you?
I missed that one. Okay. Desiree might have.
I was just going to say no, in line
just talking
you.
about billions of years to produce an optimized solution. What they did was set an artificial intelligence system to try to work out, to learn, uneducated, if it could work out where it was in three-dimensional space. And they let it run and work out the best solution for itself and tested it to say, well, now this is, we'll give you a situation in which you find yourself, and it could accurately work out where it was and what the optimum route to get from one place to another was and so forth. The really fascinating thing was that when they looked at the architecture that it had come up with, it had come up with a sort of tessellated pyramidal structure, as it were, that was identical to that you find in the hippocampus in humans, which positions us. So the computer, with a massive amount of firepower, has come up with the optimal solution, which has taken billions of years of evolution, 540 of multi-celled life, several 100,000 years of Homo sapiens to get to.
Yeah.
So I guess your point is well made, Monty, that sometimes thinking we know better than that length of evolution, saying, I'm not feeding you right now, maybe we should listen a bit more sometimes.
Yeah. That's been a huge takeaway for me in the last year, just listening to these conversations that we have, is that sometimes the intervention is not actually what needs to happen.
A lot of that on Twitter recently from the old guard in intensive care is that less is more.
Yeah.
Well, is that not
doing
true?
the least possible.
I mean, given what you and I were doing, we were transfusing people up to hemoglobins of 440 grams because it was good for oxygen delivery. We were filling their right sides. We were... giving them lots of sedation. We're giving this magic medicine, midazolam, by the bucket load.
High peak.
Yeah.
Oh, yeah, I was great at getting 12, 14 mils per kilo.
Your session, Hugh.
Yeah, so I suppose this afternoon, while you were at that one, I was judging posters. And the poster I was judging was humanizing intensive care. And I was reflecting on the fact that, as we were saying earlier on, that would never have made it into a big society meeting 10 years ago, because it would have been rat strangling and molecular biology. And it was absolutely fantastic, some of the stuff that people are doing. So essentially we all recognise that if you look at what we do to patients, it fits the ideal way to break them. So if you look at any manual ever written about torture, there are usually 20 core elements, and we do every single one of them on intensive care. And we just say, look, we're not trying to hurt you, but you just got to suck it up, right? This is all part of you getting better.
Yeah.
And we haven't really
Some
thought
people
about the ride.
listening and think that's a bit harsh, Hugh, but that has been described repeatedly in the literature, hasn't it? I mean, we've heard something about it fairly recently.
We've just gone...
It doesn't mean they were deliberately trying to torture people.
No.
It's just by default.
Things we do involve
waking people up the whole time,
right,
suctioning them,
bright lights the whole time,
noise,
sleep disturbance,
a
sensation of threat, the drugs, embarrassing nakedness, soiling. It happens. We don't try to do it to people, but we've so far gone, well, look, we're trying to cure you and save your life, so that's not our focus. And today was really inspirational. The first 2 talks were about bringing dogs onto the intensive care unit.
They're here.
They're great, they're lovely dogs. So it turns out there are 4 intensive care units now in Britain, there may be more, that have a structured process of bringing the dogs in. And you might say, well, what about infection control things? Well, apparently they have to be fed, they can't be fed raw food for some reason. They have to be vaccinated, etc., etc. But all of the studies that were there were saying that, firstly, staff are happier. Staff feel that their day got better and brighter, and in days of burnout,
we're happier here. We can see the dogs.
I've seen this phenomenon.
Yeah,
and the staff sometimes I think appreciate it more.
Yeah, and they were saying the same thing for patients, but also when they followed them up. So when it was time going to the ward, they knew the dog, and they would like to take the dog for a walk. So they started exercising. For something that seems to have no downside at all, I was really struck by the overwhelming, it was something like, the figures of like 100% of nurses and patients saying, this made my day better. Patients saying, I forgot about my pain. I didn't need so much pain relief. It gave me a reason to get out of hospital again to see my own dog, these sorts of things. So I was really impressed with that. And I was really impressed with one hospital that managed to get the money for a liaison nurse whose job it was just to be the one anchor point 9 till 5 every day for relatives. So they didn't substitute for doctors and nurses talking. They just listened in, but they were the one person. They had great feedback for people saying, you were the one person I could scream and shout at and cry and get upset with, and then I could calm down and see things differently. And it reminded me of the old days of our senior registrars in England, where we had a sort of extra supernumerary person who was there most of the time, who knew the patient, who could establish longer-term relationships.
And Hugh, the liaison nurse, was it one nurse per shift, or
no,
one nurse?
It was one person. So they raised the money half-funded through the organ donation funds to say they'll deal with that, and they raised the other half in the trust. And it was 9 till 5, not weekends, but they'd like to expand it. And universally well received by patients and relatives. So, and I could see, I'm at an age where I have friends and family who are getting poorly, and one of their constant frustrations is the fact that they're always seeing a different doctor tomorrow, or a different nurse tomorrow, or a different someone else tomorrow, and there's no continuity for them. And this seemed to solve that problem a little. So those were the big high points for me in that session, and I was just really encouraged to see really enthusiastic people wanting to make their ITU a better place.
Excellent.
I love that. I love the fact that, one, just the topics that you discussed are really cool. And I think for us who did ICU for a long time, or in critical care or surgery or whatever we're doing, it's not that we, are even consciously aware of what we're doing to people. I never even thought about that, other than whenever you would have a family member say, it's so loud, or can you quiet it down? But just the fact that we're starting to think that way and trying to do interventions for that, it's really wonderful.
There was one other I should mention too about communication. So, I try my very best to talk to patients and to hear what they have to say, but often the communication is hard. They can't talk. You get and you do.
Gotta go.
Well, I'll pop back and talk to you later. Monty will stay behind, and you just have to move, and that leaves everyone unsatisfied. So, this was an iPad app with symbols that you could point to that would turn into words and so forth. So they allowed patients the ease to communicate the things that were concerning them. And some of them, I'll ask you, some of them were quite interesting. So what do you think was persistently the two sort of highest complaints about wellness? People that said, I'm feeling
pain.
No, it wasn't, oddly enough, but keep going. Because I wouldn't have thought of these two.
Sleep disturbance?
Well, the ones of symptoms themselves were, I'm feeling hot.
Okay.
So thermoregulation. And we're not allowed fans in Britain because they're meant to spread germs. So we're letting people unable to thermoregulate. And the other was, my mouth is dry.
We talked about
50%.
Which is the National for Anaesthesia. That's number one.
Is that right?
We do the National Service for Anaesthesia.
And what I was
it used to be pain and nausea, and it's been trumped now. It's thirst.
That's fascinating, because the group that had the highest frequency were those with kidney injury.
Right.
And I was wondering whether, in fact, they're just being run dry.
Yeah.
So you might give artificial saliva, but you might also just go, I wonder if you've got enough water on board.
Yeah, that's very interesting.
There is a fear of water, isn't there? But
Yeah.
we'll come back to that maybe tomorrow, because we've been doing quite a lot of work on that in the last year, haven't we?
We have.
Hydration.
And we have young Finton, our superstar next to us, who perhaps talk about it too.
Hydration is the new microbiome.
Yes. God, that was short-lived, wasn't it? We only had that one this morning.
Don't say that too loudly around
Well, it will be in a few years' time. won't it? In a few years' time.
Well, Hugh, thank you so much for sitting down with us.
Well, thank you very much for having me.
Fantastic conversation, and hopefully we'll be back.
Looking forward to it.
All right, great.
Thanks a lot, Hugh.
Yeah,
Thanks,
thanks
Monty.
so much. Cheers.
Nick Majerison here. Thanks for downloading TopMedTalk. TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. EBPOM has been advocating perioperative medicine for many years now, using the traditional conference circuit, where people have attended meetings from all over the world and heard some of the latest information. However, in the face of the COVID crisis, EBPOM took a bold decision. We've transposed the entire conferencing experience into an online experience. Carbon-friendly conferencing. The latest information, the latest talks, the hottest experts, the most incisive analysis, and even the socialising. We've got it all covered as EBPOM goes virtual. Hot on the heels of the huge success of EBPOM 2020 live from London, we're now headed towards EBPOM Chicago. Come aboard and be part of one of the most exciting developments in medicine since the stethoscope. EBPOM Chicago. Get yourself to ebpom.org now and guarantee yourself a place at one of the most exciting conferences in the world.